Welcome back. We'd like to start the second part of this session. This is section 2 of the third edition of the CATLAB Complication course. We are broadcasting here from Shamir Medical Center in Israel, together with ADN Center of Excellence. Take places. So welcome back. We're glad to see you, or most of you, returning from the coffee break. We had the very intense, interesting, thrilling section 1 with 5 cases, 2 of them broadcasted from abroad, Milano in Spain, and 3 cases from Israel. Now we embark on the second section. We have here panelists, Professor Leor Perl from Rabin Medical Center, and Professor Elad Asher from Sharei Tzedek Medical Center, Jerusalem. And the first presenter, I hope he is already online, is Dimitar Dimitrov from University Hospital Santa Caterina, Sofia. Hello, and you're online. We can
start.
Hi
guys. Can you hear me?
Absolutely.
Thank you very much for the opportunity to present this case. I'm honored. This is our second year participation in your course. Last year, my friend Dr. Alexandrov presented the case with the fractured catheter. So I hope my case today will be at least as much interesting as it was his. So once again, thank you for the opportunity. My case is about a 50 years old male patient that was admitted in our hospital with exertional dyspnea for several months. He had typical comorbidities, arterial hypertension, diabetes. He was a current smoker. His ECG on admission and echocardiography were normal with preserved normal ejection fraction and no valvular abnormalities. We performed a coronary angiography, which we registered 2 vessel disease. Ad hoc PCI of the circ was done, and we noticed this CTO of the RCA in the middle portion, which is quite torturous. That's why we did a CT scan, which confirmed the CTO body was without very much calcium, but a possible microchannel existed through the body of the CTO. So we tried to do PCI, to do CTO PCI of the RCA with antegrade wire escalation strategy. I started with a double lumen microcatheter parked in the right ventricular branch, and with a lot of different wires, I was able to go through the occlusion in the vessel architecture, but it was not possible to go from the extrapleural space into the true lumen and to make a re-entry, although I tried a lot of different wires, even with a recross catheter. So at this point, I decided to stop, and we have a CTO course in our hospital with a proctor from abroad. So we scheduled the patient for a second attempt with the proctor on site. This time we started directly retrogradely, so we had a debut in the left main, and we traveled through the septal branches with the Sion black wire, and we parked Corsair Pro XS catheter in the distal RCA. We confirmed with tip injection that we're in the true lumen just before the distal cap. And that's when our problems started. We tried a lot of different wires, but the vessel was quite torturous. Many attempts were made, but finally we were able to go through the CTO of the body with a knuckled Guadius EX, which found its way into the aorta. We did a tip-in the guiding catheter, and then we did some predilations of the RCA and prepared the artery. So this is the angio that we got, patent side branches, good telemetry flow in the RCA, maybe some dissections. At this point, I would like to ask the panel and all the participants, how would they proceed from here? Would you do only DCB? It's popular now these days. Or you go pedal to the metal, full metal jacket, maybe a hybrid approach, DAS plus DCB, or maybe intravascular imaging to decide what to do.
So the situation is like this. You opened the RCA in the retrograde manner with a knuckled wire that find the way into aorta through the true lumen or subintimal space, we don't know. And you got the anterograde flow, which looks quite well, a long segment, probably dissected or not. And the question is whether to do DCB, whether to put the stand, it will be a long stand, metal jacket, use the combination of drug-eluting stand and DCB, and then we have to talk where to put which device, or to do intravascular imaging to understand what we have there in the artery and to be more precise choosing the treatment modality. So far we have the most answers are supporting the intravascular imaging. What do you think?
Well, I think, first of all, you see most of the audience opted for the intravascular imaging. I think in these conferences, it's always the right answer. But in real life, there's the dissection. There's an artery that you need to treat. Whether DES only or DES with DCB, that's an open question. But I think even using an IVUS or an OCT has a price sometimes. And it's time. It does have its own complications, and the question is, what are you looking for? Although the studies show that any kind of complex PCI with intravascular imaging reduce complications, improve results, I think the question here is, what are you looking for in the intravascular imaging? And I would ask the audience if they would want to answer, what are the things you're looking to see in intravascular imaging?
The question to the non-CT operators, okay? Clearing out the CTO, setting CTO background of this case. Did the artery with dissection in the proximal part, okay? Most of us may agree that there is a dissection. How would you do the case of dissected proximal and long segment of RCA? How would you choose the proper device to treat? DES, DCB, where, how, and when?
I think there is also a dissection in this part of the RCA. This is a 50 years old guy. It's not like 94 years old guy. And especially if you have dissection in the distal part, you have to stand that, and then you have to continue all the way up. And remember, it's not the LAD. RCA is like a tube, and the most important part of the RCA is the PDA and the PLB. Otherwise, if you're going to compromise the flow there, no blood supply is going to go to those parts. So in this case, I fully agree with Lior. I mean, imaging is okay. You can do it if you want to. You have a price to pay sometimes. But I don't see how you get away without stenting the distal part and then go up.
So although the audience supports imaging, panel supports stenting, the dissected segment of artery, maybe all the length up to the ostium, like a DES metal jacket. So what did you do?
Thank you for the comments. Intravascular imaging.
Wait a minute, we have
Yeah,
another
just
comment.
want to emphasize one thing. Look at the distal part of the artery. This is a tiny RCA with no runoff. In these cases, and there's also an evidence supporting it, if you put a full metal jacket here, the risk or the rate of silent reocclusion, if you do a mandatory repeated angio, is 80-90%. So you can put a full metal jacket, but if you don't have a good runoff of the artery, it's a small, tiny RCA, the long-term results are going to be very bad.
Just a case of argument, distal artery, distal bed usually grows after you restore the blood flow, even in a very surprising manner. You can do follow-up angio and see how large actually these branches are. So we are, this is the situation. We support imaging and probably stenting all the artery.
Thank you for all the comments. They were absolutely correct and well said. What we did, we decided to do hybrid approach. We decided to stent the distal dissection. Probably we should have used a longer stent, and to do some DCB proximally, because the CTO body does not look so dissected and it's not that bad. But when we placed the distal stent, you see here, we got proximal expansion of the dissection, which was not good. So then we had no other option but to stent all the way near to the ostium, which was not our first intention. But we stented with a long stent, 50 millimeters, two stents actually. And as you can appreciate, in the proximal part behind the stent, there is something. There's dissection, which is not completely compressed. And with the second injection and the third, something very, very wrong and bad is happening over there. We have a lot of haziness, and we've lost all the significant side branches with what we have done. So additional ballooning was done, which only worsened the picture. Then we decided to use IVAS. The IVAS showed huge hematoma around the vessel with a well-expanded stent. But we lost the PDA. This is a huge artery. This is a right dominance artery. We had a big PDA over there, which is lost now. We lost the right ventricular branch that we used for anchor, and we lost almost completely lost the conus branch. So this was late in the evening, maybe 9 o'clock. This was our 9th case for 2 days. So we decided to stop here. We sent the patient to the ICU. He kept complaining very interestingly of continuous non-stop hiccups. But the ECG was normal. He had mild chest pain. His ejection fraction was preserved. No pericardial effusion. So I said, let's go. Let's finish the course and go home. But half an hour later, the patient suffered sudden cardiac arrest. CPR was initiated. I was still there. On the monitor, we saw polymorphic ventricular tachycardia, which prompted immediate cardioversion, DC. We recovered heart function, and I rushed the patient back into the cath lab. I was thinking that I had stent thrombosis of the RCA. But fortunately, the haziness was still there, but the RCA was with TIMI 3 flow. I did additional, but I didn't know what else I can do, so I did additional ballooning with a 5.0 balloon. I previously used a 4.0 stent in the proximal part, post-dilated before the CPR with 4.5. Now I used 5.0 balloon, and this is the final angio that I got from there. A good metal tubing, which is not what I wanted, with no side branches, but I had this distal patent still posterolateral branch. So I stopped there. The patient was extubated 8 hours later. Maximum rise in the EMB fraction was 3 or 4 times above the normal limit. We discharged the patient 3 days later with preserved ejection fraction and without any other complication. So this is the follow-up angio that I did 1 month later. You see, all the branches are back, hopefully and thankfully, and we got the PD. So this is the final result that we had acquired. As a take-home message, maybe I would like to say that stenting dissections can cause milking effect, leading to huge propagation of the dissections and hematoma proximally or distally. In our case, it was proximally. Every injection only worsens and enlarges the hematoma. Probably the proximal RCA was partially dissected by the knuckled wire, which was in the extraplug space. And most important, my take home for me message is that even in CTO, the loss of significant side branches can cause lead to huge amount of ischemia, which could potentially lead to lethal arrhythmias. So during our CTO procedures, we should make every effort to preserve as many branches as we can. Thank you for your attention.
First of all, I think it's really a great case, and the last images that you showed, it's incredible. So congratulations for this case. But again, in retrospect, would you do anything differently? Maybe, you know, I'm not a CTO operator, but you think you should do this case because there was the CTO, but I think you had good collaterals to the RCA before starting the procedure.
The problem was that we had to inject antigravely because the collaterals from the left system were not that good. And when there was a huge microchannel that I thought that we can tackle from retrograde with a soft wire, which was not, we tried SU03, but it was not possible, then we got aggressive. And he had, for me, he had complaints of stable angina, so he's a young guy. I'm not thinking about our indications. We had indications to do CTO PCI. What I would have done differently is maybe I would have tried to preserve the PD with the double woman microcatheter to not lose it in the front of the procedure, and maybe only ballooning, no stents, because stents here made worse the picture. I think only DCBs, maybe, I don't know, maybe would have been better, but fortunately this patient now is okay. He has all side branches, he has his RCA patent, so, but maybe stenting was not the right decision, I don't know.
I don't understand what was the mechanism of his heart, cardiac arrest. Definitely
I'm still not sure, but for me it was because he had periprocedural MI. He had rise in the troponin, he had rise in the other markers. So for me, the loss of the PD, the loss of the side branches caused ischemia. He had complaints after the procedure. He was suffering from chest pain.
I think that.
So
I beg your pardon. I think that one of your runs of pictures after the event showed that there was some haziness and some maybe tissue or thrombus inside the artery. And when you put stent, leaving a huge hematoma outside the artery, you will deal with thrombus outside the stent, and it may propagate and partially compromise flow in the stented area, in the stented artery. Maybe this was the problem. So this takes us back to the decision to put stents in dissection without knowing what is the true wire position. We can almost for sure say that the retrograde wire went through the subintimal space. So it was knuckled wire. We know how it works in CTO. And knowing that, I think that the decision to put the stent must be taken after you do some intravascular imaging and making decision based on the position of the wire in each segment of the artery.
I want to be provocative and ask, for those who are strong DCB supporters, in a case like that where you have a hematoma, and it's not only, I agree, I think that it was a thrombotic mechanism as well. There's at least one picture, it looks very hazy, it looks like a thrombus, but also there is a physical compression of the artery from the hematoma. This is not just a microscopic process, it's an actual mechanical compression of the stent, I think. And would you have felt safe to do a DCB in this case?
Yes, I would. In my opinion, I would do the imaging. Yes, but if I would see the multiple non-flow limiting dissections, I will see this as a blessing. I will maybe even make it worse in brackets. Taking some cutting balloon to expand this dissection and then definitely do a drug-coated balloon. Because this artery is negatively remodeled, it might expand and grow to the larger numbers like 4.0 or something like that. We have a good teeny flow. It's not a matter of how it looks at the end of the procedure, it's a matter of how it works at the end of the procedure. When you have multiple side branches, end branches, and good flow, even the artery is dissected, it is better for me in the CTO scenario, to leave it dissected and to heal with the help of DCB.
Okay, thank you very much. For the sake of time, we're going to continue to the next case.
Thank you very much.
Again, thank you for having me. Okay?
That's been all.
So the next case, I'm happy to invite Professor Olad Mo from Shiva Medical Center, navigating a navitor through a navitor.
Thank you, Ilya. Thank you, Sav, and the organizers. So we'll just go directly to the case. You can, from the title, you understand what will happen here, but let's go step by step. So I present you a 69-year-old female with a severe AS, aortic valve area of 0.5. Here you can see the anatomy. Very important, she's after a mechanical MVR because of rheumatic heart disease. So following discussion with surgeons, even though she's relatively young, it's a redo. So the decision was to go with the TAVI. Here you can see that there is no significant PAD. Narrow complex QRS. So then when we discuss patient journey, then the question is what valve? Here you can see anatomy. So important to note, the valve, the perimeter and the area derived. So we're talking about a 22.3. So it's a borderline case. We decided to go with the navitor. So the annulus is borderline between a 25 and a 27. And the distance from the mechanical MVR is less than 4 millimeters, so there are some challenges here. We have good experience with the navitor. It gives us good hemodynamics. One of the reasons we decided to go with navitor was because of relatively small sinuses and the fact that we wanted to have good hemodynamics for the future. It's important for the case to understand the anatomy of the navitor. That's why I'm showing you these pictures. So the perimeter derived was between 22.3 and 23.2. So it's the borderline between 25 and 27. So I decided to go with the 27. We're thinking about, larger area, larger orifice. So here we start. So everything started well. Here you can see the mechanical valve. You can see the root injection. You can see valve crossing. Nothing to write home about here. Okay, everything went really well. I was optimistic at this point. Here you can see predilatation with an 18 millimeter balloon. Osipka again. No significant challenges here. And as EC always tell me, Professor Barbash, say fluoro, I'd say fluoro, and I didn't say fluoro. So I don't have the implantation itself, but I do have 3 images of valve positioning, and trust me, the right one is really just a second before I release the valve, okay? So I'm positioning it, I'm relatively happy. I try to be higher than lower because of the mechanical valve. And this is what I got. So following implantation, you see that the valve is underexpanded and it migrated distally, right? Up it's distal, Sav? Upward is distal or proximal? It's distal, no? Okay. So we had a lot of challenges with nose cone removal because the stent, the struts of the navitor were underexpanded. I must say I was surprised because there wasn't too many calcification and I had good predilatation, so I was quite happy. But again, it was very difficult to pull the nose cone out. So when we eventually took it out, the valve embolized even further. Okay, so now comes the question. Everybody's ready with the application. Okay. What would you do? You have a 69-year-old lady with a mechanical MVR, with a navitor embolized and underexpanded to the aorta. Okay? So I think if you didn't see something like this, you're probably not doing enough TAVRs, because valves do tend to embolize with all companies. Okay? So I give you 4 options. Maybe other people would give other options. You can send her to CV surgery, stop the case. She's stable, right? You can stop the case, send her to CV surgery, option number 1. You can snare the valve, like anchor the valve and push another through the valve. You can put another navitor, you can put another sapien maybe. Or you can post-dilate first because you would, as an underexpanded, snare it or anchor it, and then implant another valve. Okay, let's see. So the title was Navitor through a Navitor, so, okay, but still. Okay, so, it's 10 people or 11 people saying snare the valve and implant another Navitor, and 6 people think that we should post-dilate first, snare the valve, and then implant another Navitor. 1 person thinks we should send her to CV surgery, and 3 would put a sapien. Okay. Okay. So most people think that we should snare the valve and implant, anchor the valve and put another. So that's not what we did. We went with 4. And this is what happened. So first of all, we post-dilated because we were concerned that we will not be able to advance another valve through the underexpanded valve. So we post-dilated. When we post-dilated, it went even a little bit further up. And we got bilateral coronary occlusion. At this time, patient collapses completely. No blood pressure, and we go to full PCR. You can see there is no coronary flow. Just to help you with understanding the anatomy, you can see here, so full PCR, no blood pressure, no contraction of the heart. So during PCR, while the patient is in full PCR, we used a Terumo wire and snared the valve upward. And then we got the coronary blood flow. So I want to show you root injection before and after the snare. Okay, this is before the snare and after the snare. You see? Everybody can appreciate the coronary. And then, any comments at this point before we go forward? Elad, Lior?
We are shocked.
Easy. What?
Speechless.
Can we ask about Elad? Sar wanted provocative cases.
What was the
okay.
Elad?
Yeah.
What was the calcium score of the valve before? Was it a rheumatic valve? I'm here.
No, it wasn't. I showed the pictures. It wasn't too calcified. Yeah.
That's my question.
Yeah.
How do we prepare for a non-calcified valve when we need to implant an exact location? I had a similar just the other day, and it jumped in. I'm saying, how can we be better prepared for a non-calcified annulus? I think you chose a 27, which is a good idea to go large.
Yeah, first of all, because the Navitor's radial force is not as strong as others, I felt comfortable with pre-dilating with an 18. As for the 27 versus 25, I have some learning points for the end, but if I say it right now, I think that the 27 was a little bit too large. We'll review the anatomy again at the end. I remind you the measurements were exactly at the borderline between 25 and 27.
And just maybe snare before snare it up, and then maybe it will grow by itself, by its own force, or only then post-dilate if needed.
Yeah, that was the main learning point. But so let's see. So I showed you the root injection before and after. Here you can see positioning the second valve, implanting the second valve, releasing the second valve. Would you post-dilate again? You wouldn't. So we did post-dilate again.
What is the hemodynamic result?
I'll show you everything at the end. We didn't check hemodynamics before post-dilating because it looked, as you can see on the left side, it was definitely undersized, underexpanded. So we post-dilated again. At 25 this time, yes, it was 25. Good. Thank you, Elad, for a very good point. This is the final result. Mechanical valve is working well. Coronaries are wide open. No leak. Here you can see the releasing of the snare. Lior, you're asking about final hemodynamics. You can see invasive at the end of the procedure 4 millimeters, next morning 6 millimeters. So we have good hemodynamics for a 69-year-old patient. And with permission of the patient, here is the patient. Let's see if it works. The video is not working, but this is the patient the next morning. She was not intubated. She was not intubated. We didn't have to intubate her. We did a CPR, snare with a trauma wire, and proceed with the case. So let's see. I have some learning points that I took from this case, but maybe some people want to comment here. What would you do different?
I will just say, first of all, this is congratulations on surviving this case. Not only the patient, but you as well. I think the part where the snaring ended in bilateral coronary occlusion, just to get out of that with the patient not only alive but well, is amazing. One point that I've learned in cases from our center is that when you mess around with the TAVRs in the ascending aorta, make sure there's no significant trauma. We do a CT in these cases, and we just want, because you can create a dissection or a hematoma, and then I'll just ask you. I'll get back to you to ask what do you think was the mechanism of the dislodgement?
Yeah. So I have two. Thank you, Leo. I think the mechanism of dislodgement was oversizing. That's because I did aim high, but I aimed high on purpose because of the mechanical MVR. There are catastrophic complications with MVR. But here is my last slide, my learning points. First of all, this is a humbling procedure for me, but I am fortunate. I'm really fortunate to work at Sheba because I have a lot of experienced operators next to me outside the room. So Victor is maybe 20 years more experienced than me. Segev is maybe 15 years more experienced than me. Pfeffer, Barbash, all of them are extremely experienced. So the snaring with the trauma wire, doing PCR was a very fast decision maker that helped me to avoid the need to intubate the patient and actually save their life. And the fact that there were experienced operators with me in the room that morning really helped, okay? And then for your question, Leo, I think you have to respect the LVOT diameter. So if you look at the numbers again, the Navitor cutoff for 27 is 23. The annulus diameter in multiple measurements, both us and the clinical specialists of Navitor, was between 22.3 and 23.2. So we decided to go oversized because she's young, we want a large valve, she might need another valve in the future, it's intraannular. But if you look again, the LVOT diameter was actually much smaller and not even close to the cutoff of 23. So I think my learning point from this case is always to respect the LVOT, even if it's not a bicuspid, even if pre-leaflet annulus valve, and respect the LVOT. I think the hint here was the LVOT. Thank you.
Somebody from the audience?
Just one comment. Very nice case. I haven't seen it until now.
You weren't in the hospital. I should have taken your picture out.
The only thing before you modify the valve, if you have embolization, you have to make sure that it's not at the level of the coronary arteries. So first, snare, pull it above the coronary arteries, and then if you want, you can dilate it. But make sure you're not at the level, because if you don't pull it high enough and you put a second valve, even if you don't dilate it, you will occlude the coronary arteries.
I'm just going to say one more thing. The theoretical advantage, you show the slide of the tapered versus non-tapered part of the Evolute versus the Navitor. I think with the Navitor, which is a great valve, there's less flexibility in the sense that if you move a little higher or lower with the Evolute, you can get a little different diameter in the annulus, right? So I'm not sure it would have happened with that as well, but that's something to think about. But anyway, amazing case, really great case.
Thank you.
So it's my pleasure to invite Professor Eyal Ben-Assa from Asuta Medical Center. And he's going to talk about catastrophe, after party of dual tier.
Good afternoon. Yeah, we don't see the... כזה? Okay, so it's not so frightening, and there's no blood in the pericard and no CPR on the table, but we see more and more tear procedures, and with difficulty in imaging and learning about how to image well and how to grasp well the leaflets. And I want to present to you a case we had about a year ago, actually. It was done with Dr. Harari, who had to go to do a STEMI instead of me, so I'm and we had also the luxury of Professor Shuvi to be our proctor and Professor Carasso to be the echo part. So we had a really good team there, and yet, as you see, it wasn't as expected. A very sick gentleman, 73 years old, ischemic heart disease, ischemic cardiomyopathy with 20% LV ejection fraction, and also RV failure, COPD, smoker, creatinine of 2.5, bypass, and CRTD. And it is known for a while now that he has all these, but in the last 6 months he was decompensated, hospitalized again and again, mainly with RV failure, but also with LV dysfunction, decompensation, and the current hospitalization was with anasarca, pulmonary congestion, ascites, and creatinine that went up to 3.5. And in the echo, and I will try not to show too much imaging, although during TEER it's difficult not to tackle them, but if we see the pre-procedural echo, it's an ejection fraction of 20 and an RV dilated and mildly reduced function, biatrial enlargement. There was a moderate to severe functional mitral regurgitation, as you can see both on the transthoracic and the transesophageal. It was a centrally located A2P2 jet, and the length of the posterior leaflet was 12, so we thought that the mitral would be quite an easy tear. We were not right about that, but that was our thought. But the main problem that he had was a significant TR. It is a lead-associated TR. If you remember, Professor Glickson gave a very good lecture just the other in the valve that we had, that it can be lead related, or that it means that the lead itself moves the leaflet and obstruct the tricuspid valve, or just lead associated, means there is a lead there, but it doesn't obstruct, but it will interfere with the procedure. This is more lead associated. The lead itself does not make the problem, but we do have a large annulus of 51, massive TR with vena contracta of 15, wide IVC, and I will try to show you a bit more and more about the way we look at our tricuspid valve, because during our journey with tricuspid TR, we've learned more and more about how to appreciate the degree of difficulty with the TR. But let's go to the case. We thought that we will start with a quick mitral side TR. We opt to use a centrally location P10 or a Pascal clasp that have a 10 millimeter width. It has a larger, I forgot, spacer that will allow us a good sealing of the central without pulling the leaflet too much. And we thought that we will be able to put only one single clasp in the center. And then I want to show you slowly, this is the procedure itself. We're looking at the mitral valve, anterior leaflet, posterior leaflet, a very central located jet. This is the clasp above it. And when we put the clasp in the center, you see there is a residual jet, medial to the clasp. This is the septum, this is the medial part, and we thought that this is not good enough. So we opened the clasp and tried to place it a bit more medially. So we moved again and again, and although we placed it a couple of times, each time we still had a residual leak medially,
Eventually we went quite medial, almost to the commissure, maybe too much to my opinion, but I want to show you what happened when we are after placing one clasp. Here you see the clasp. You can see the width of it. You will see the next clasp will be not as wide. You see that it stands well, but there is a residual leak lateral to it, so we came with another clasp, this time placing it a bit more centrally. Here we see a short axis. This is something Professor Carasso shows us a lot. This is the first clasp, and this is the second one. And eventually we have two clasps, and we have, here it looks mild MR, but here we would say a bit mild to moderate MR, but we have a reasonable results on the mitral side, and then we said, okay, let's go to the tricuspid part. And the tricuspid part is a bit more challenging, specifically in the visualization. I'm showing you this image because, as I'll show you soon, we've learned to use the transgastric view that make us look at the valve in this way. We will see the echo probe will be here. We will have a posterior leaflet on top, a septal leaflet on the right side, and an anterior leaflet on the part. And we decided, since it's a large regurgitation, we wanted to do what is called the Clover technique, which means we put one on the anteroseptal area, another on the posterior, between the posterior and the septal, the first one between the anterior and the septal, and hopefully leaving the lead here, locking it or capturing it in this commissure between the posterior and the septal leaflet. We know that doing such a technique also make an annuloplasty and allows the valve to behave better. But if you want to make God laugh, tell him about your plans. This is so a short explanation, because I do show you some imaging. So I want to teach you that at the beginning, when we started to do tricuspid tear, we didn't know exactly. We were trying again and again to understand the anatomy, and I think now there is a very rigid way to check it. And this is an RV inflow-outflow tract. If this is the aorta here, we see this is the right atrium, this is the inflow of the RV, and this is the outflow to the pulmonary artery. And we always will know that this is an anterior leaflet, and this is a posterior leaflet. And if we explain in B on the posterior leaflet, we will know that we will see a septal and a posterior, and we can explain on the other one. But this is, for me, a very good image. I showed you before what we are planned, and on the transgastric view, we see a septal leaflet, an anterior leaflet, and a posterior leaflet, and we're trying to move between those two images. So let me show you. I took, just to say, we know that there is a lot of complexity in the tricuspid valve. This is just from the end of 2024, and we see that there are many issues to look at them before the procedure: the gap, the location of the jet, the image quality, which is a very important issue, the corridor structure, and if we collect more than 3 or 4 points, we have less than 25% success rate. That if we have only 1 or 2 points, we are about 70–80%. So there's a lot of variability, and we need to understand where we're entering. So let's start at, this is a bit, okay. So this is the RV inflow-outflow. Here is a lead and that is in the posterior way, and this is our clasp going towards the anterior leaflet. Unfortunately, this jumps on and off, and it's not so nice, so I'll move again. But here is a... Yeah, I don't like this. Okay, so here, I'll have it move, but this is a clasp going between the septal and the anterior, and this is the lead itself. Let's see if we can see it there. Hopefully the other will be better. Again, we have a clasp. The first one is slightly, many times difficult to see. We think we were in a good location, anterior, and we see that we are catching well the anterior leaflet and the septal leaflet. We're looking here again. Okay. It worked before. And I want to show you this is the lead and this is the clasp. And now we ask ourselves to release or not to release. And in PCI, everything is much more faster, but in TIR, we have a discussion, what the echo guy says, what do you think? There's about 20-minute discussion about here and to release. And eventually, we decided to release. We thought that we have a good capture of the anterior leaflet and the septal leaflet. And this is what we have. I hope this will run. This is a very jumpy. Okay. I was trying to. אתה עוזר לי? כן, דווקא שבחזרה זה עבד טוב. Okay. Okay, so now we have a jumping clasp, as you can see here. And you can see this is the first mitral clasp, this is the second one. You can see the difference between them. And we have a single leaflet detachment that the clasp is holding the anterior side, but is not holding the septal side. And this, you can see a clasp jumps up and down here through the tricuspid valve. And now what we have is an attempted clasp on the tricuspid valve with a single leaflet detachment, detached from the septal leaflet. We have a significant ER. We have a clasp jumping up and down from the RV to the RA. And the question is what to do exactly. Let me see. For some reason, can you replace it? I see that they see my screen and I see. So what should we do? Stop now because enough is enough. Add one more clasp. Try to help stabilize it. Add two more clasps from both sides. Try to even further stabilize it, or send to surgery. We were thinking that enough is enough for a while, but the patient is 74, very diseased patient. I don't think he can hold the surgery, although it's always an option that we need to think. Usually, when we have an SLD, we like to add another clasp next to it to try to stabilize it. In this case, since it was so much movement in the clasp, we thought that adding two. Really have fun today with the. אתה רוצה לעזור לי? עוד פעם? כן. בוא נצא let's go and present it again. Okay. Okay. As what we opted to do is try to stabilize it with two more clasps, thinking that we'll start with the first one, of course, but this was detached. This is the X here, so it's now only connected to the anterior leaflet, and we believe that if we will add a posterior leaflet and an anterior leaflet to septal, we will be able to hold it stronger there. So, and well, it works. So now we need to go posteriorly to the clasp that we already have. Posterior is on the echo, the upper part, but on the fluoro will be below the clasp that is already there. So we manage between fluoro where we see a clasp and we will come below it. And in the echo, we need to place a new clasp above it. You see that we go towards the posterior side. This is the lead. This is the new clasp, and here you can see jumping on and off the older clasp. We see above the, searching to see if we're in a good position, trying to place it better. Again, here it's after capturing the leaflets in a posterior area. Here you can see a jumping clip, a new clasp, and a lead above it. Again, this is the posterior leaflet. Here it's a septal leaflet, and here is the anterior leaflet, and you can see all three parts here, I hope. And then you see that this is a clasp that is posterior, it's below, and it holds very well, but it did not stop the SLD clasp from jumping. And then we said, okay, let's try to put one just above him. It means anteriorly to him, in order to help it work. This is, as you can see, we still have significant DR. And then a third clasp is arriving. Now we are trying to come here. This is more anterior. I hope you are the master of the anterior that will be here. Here you see we come on the anterior leaflet. Again, trying to hold it. And you can see here before the release, this is the clasp that is jumping. This is a clasp that we placed before, and now we're coming with an anterior clasp. And before we released it, it looks that it helps it its stabilization. You see, it kind of hold it in a way, but indeed after release, we have a jumping situation. What we do have is, and this is the reason I wanted to call it a party in the atria, if you can understand my discotheque. Anyway, after a lot of analysis, what I'll show you again, but basically the first clasp that had a single leaflet detachment is for sure detached, but the one above it stayed quite connected, and it's just the interaction between them that looks so funny, unhappy, everyone. So we said, okay, enough is enough. Now it's the part where we said enough is enough. And when pulling out the system, we're in the tricuspid, in the right atrium, we see that the iatrogenic ASD has a bidirectional flow. It means that the shunt goes from right to left and also from left to right. We have high pressure in the right atrium of about 12 to 15. We have a wedge of about the same. And then the question that we ask ourselves, should we leave it? Sometimes we know that leaving this is a V wave, for example, as a shunt, or would he deteriorate? We were waiting to see if he becomes hypoxic. He did not become too much hypoxic, but waiting still left us with this bidirectional, very clear shunt. So this is our other dilemma. Should we close the ASD iatrogenic now? Should we try to assess LA pressure with some maneuver? Should we reassess the shunt in a few days, leave it like that, and then come and close her later? There's no need to close it, never an iatrogenic ASD. What do you say?
How long have you been in the cath lab for now?
Yeah, about 5 minutes. It's a long procedure, as we understand, where every step you plan you need to retackle it. Luckily for the TR clip that the patient is steady, also for the mitral clip, that the risk of TR are very low, and this is even in such a disease patient.
Was there any change in saturation?
So we wait. He was the same 92, 93 saturation the whole procedure. It wasn't, but it didn't reduce. It was not. It didn't become hypoxic. So I think the reassessment of shunt in a few days or the closing it now are both an option. We thought at that time that we want to close it because this patient has an RV overload with the main problem is this ascites and the RV load. and we decided we should close the ASD. It's a relatively easy procedure. It's a central hole. We know the size. It's a 12 millimeter ASD closure. You can see here the closure procedure. And this is the final image, as you can see, with the ASD, with the jumping clasp. So, just to say the aftermath. So mitral 2 clasp with a residual mild to moderate MR. Tricuspid 3 clasp with 1 septal leaflet SLD but residual moderate to severe TR, and a long time in the cath lab. The patient, we want to say, improved for a month or two, but then deteriorate again. So we didn't help the patient as much as we wanted, and it was a case that we looked at it again and again and trying to learn, was it not the patient that we should have chosen for TIR? Was an image issue that we've learned. We had really both Professor Shuvi and Carasso, that are, at least in Israel, are very experienced in this field. This is the case. I wanted to share it with you. We're learning more and more. We started to do in Assuta Ashdod now, and we had a very fast TR clip, and on the other day we had a case we couldn't clasp and took the patient off the table. But imaging is a difficult in TR. Sometimes it's very easy, sometimes it's not. We need to learn when to bring the patient and when to say no from the beginning. It's not so easy for us to say no, but we need to learn it. I think the question what to do with an SLD, I will be happy to hear from the experienced operator here, but there's many things that you can do around. And when to send to surgery is another question. People are amended. Sometimes it's an option that we need to remember. That's all.
So I will just make a few comments, if you will. I think this is an unbelievable case, but it might happen again. The complication of SLD in these cases is one you have to know how to deal with. And your question, I think you've presented it well, also showing the anatomy and the consideration. So, and got out of the cath lab okay with that patient. I think that by itself is an accomplishment. I do, however, have a few comments from our experience, and I see a lot in Ihab and Nadav here. There is a question of timing of dealing with the tricuspid valve, and this is a discussion that keeps coming up, but we know that in more than 40% of the patients, TR significantly improves after dealing with the mitral side. That goes back to the reduction in type 2 pulmonary hypertension and so on. And so, at least in our center, in the Rabin Medical Center, we have stopped completely doing mitral and tricuspid at the same day. I think especially in challenging cases such as this, which brings me to the second point. I think that what you've shown is electrode, the etiology for the TR is the electrode. It's definitely a major part. Let's say it's a major part of the regurgitation. And in these cases, although we have done one or two cases when we've tried to grasp both sides of the electrode, I think that should have not been a case for TIR, personally. I think that was too risky. In some cases, the electrode is there, but it's not the mechanism of TR, which is fine. Just stay away from it. And I think that's why you've had an SLD once, and when you got more posterior, closer to the electrode, you had another SLD. Because you can't negotiate with the electrode. It's stronger than the grasp, and it'll just pull the septal leaflet outside of the clasp. The final part is, I do think you should have sent that patient to surgery immediately. The patient is stable. As you've mentioned, these cases are usually, especially on the tricuspid side, very hemodynamically stable, which gives you the benefit of time and no damage done. We've started explaining to all the patients that it might end up in surgery. And I think once you've closed the ASD, with that result, with the two clips or clasps running around in your atria, I do think that patient should go to surgery and get an excellent result for a patient who's not very old. Those are my comments. Any comments from the crowd, from the audience?
This case calls for a simulator for these procedures. I mean, you can't just go and start doing these things. You'll have to have a simulator, and to do things on a simulator, and only after that, once you feel sure, go to the patients, to real life.
I couldn't agree more with Lior. I think that we have to be very careful with left side disease, left heart side disease. I think all centers in Israel stopped doing mitral and tricuspid together. I think the fact that many of these patients, if you look at the Triluminate, at the control group of the Triluminate and also other studies, the control group, after you see that 25-30% of patients improved in the control group with no clip. So diuretics and left heart disease management can be enough for some of these patients, especially if there is significant MR, even in cases that Amit always mentioned, the diastolic dysfunction. I think we have to be very careful and stay away from left heart disease for patients with severe TR, because these cases, as you described yourself, the patient didn't do well. This is a marker of end-stage heart failure that involves left heart disease. So in this case, I would go for the mitral, stop, reassess, give more diuretics, and hope for the best.
Just to remind you, it's a case from a year ago. There was no possibility to do this. That's what we're doing now. We're separating them. A year ago, we could only do it as a joint procedure. Also, the mitral part was frustrating for me. I agree with you with simulator. We have a lot of experience with mitral. We've been working for a couple of years now at Sccci Tzedek. And I think in the mitral we have very good success. The tricuspid we all learn together now. I actually think that the lead was there, but was only there to hustle the procedure, but was not pushing the septals away. And I think I should learn more and more which are the patients that will be easier or not easy. We can discuss eyes bringing to the tricuspid area, and maybe this will improve. I totally agree. For the eyes that is arriving, I think that mitral should be done first, and then to wait and see how patient is improving. That's it.
Thank you. Fantastic case. Really insane case. We learned a lot from this. The next presenter is our good friend Alex Achim from Cluj-Napoca Heart Institute in Romania. We are very happy to see you here, Alex, and the floor is yours.
Hi, Ilya. Is the sound and the video quality okay?
Fantastic.
Fantastic, thank you. So hi everyone, my name is, as Ilya said, I'm Alex from Cluj, Romania. It's the second largest city from Romania. Actually, I'm situated in the middle of Transylvania. For me, it's a real pleasure to be with you. I see that you are also physically in Israel. It's good to see you. Also, it's a fresh air for me to be with you. You know, working in Romania sometimes is very. We have many patients and sometimes gets very chaotic. So it's really nice to share sometimes cases with you and discuss and so on. I will present you now a coronary case, a complication case about a type of coronary perforation that sometimes it gets missed or it's not missed, but it's not so often. And I want to share with you a simple and creative method how to diagnose it and treat it, actually, or not to treat it. But before going to the case, just to remember you, we are all familiar with the coronary perforation and the Ellis classification. And we know the 1, 2, 3 types and where we put stent grafts and coils and so on. But we also have the class 3C perforation, which means perforation into an anatomic cavity of the heart. I'm not sure who's a CTO operator sometimes encounters these types of perforation. Usually are doing CTO or PCI. Actually, this case is from Austria when I was a fellow there and learning CTO PCI. It's a sad case actually of a 70 years old male patient. You can see on the right top side of the screen that he has a huge history. And why is a sad case? Because he was 2 times operated with cabbage and 2 times with a venous graft on the LAD. So venous graft 2000, and of course the vein graft got occluded. So he received a redo surgery 5 years later on the same LAD. Of course, that got occluded again, and then he received PCI again 5 years later. Left main LAD PCI, and you can see on the right screen now on the angio the 2 sides of the anastomosis of the venous graft, one here and one more distally, and you can see how angulated and pulled now the LAD is because of those anastomosis, and actually presented now with unstable angina, probably due to those 2 lesions at the level of the 2 anastomosis, this one proximally and this one more distally, which is more hard, more difficult to wire, also with the post-stenotic aneurysma. Of course, it was really difficult to wire this lesion. You can see on the second image that we played with many wires, many hydrophilic wires. Eventually, we could advance a whisper. I'm not sure if you use that. I don't like that wire anymore, but it was a good wire back then. We used the whisper. It's a slippery wire to get down through these lesions. And then we did our normal PCI of the left main LAD. Important to notice that you can see that the field of working, the projection is collimated, so we are focusing only on the proximal LAD and the left main, so we don't see the back end of the wire, we don't see the apex of the heart. And this actually, we worked like this for 1 hour when we didn't care too much about the whisper. We did a good PCI, we were happy about the result. We were just preparing to finish the procedure and go and grab a coffee, but then we extended the collimation field, and this is the final angio after we wanted to finish the procedure. Of course, we got really scared. It's a horrible image. It's a huge staining of the apical part of the LAD. We quickly advanced. Oh no, sorry. I think now it's the time to discuss what would you do in this situation, and try to vote, and then I will show you what we did. Of course, one option would be to inflate a balloon. One would be nothing, just to finish the procedure. One would be to call the surgeon, and the 4th option would be coil. Of course, you need to seal the perforation.
What about lipid or fat injection?
Yes, coil or fat. But it's important to note that we inflated the balloon 5 minutes and we injected again, and the image was the same, so it remained the same. But more interestingly, the pericardium was free, so we didn't have any blood in the pericardium, and the patient was stable.
Okay, so we proceed usually in these cases, in any case of perforation, coronary perforation, proceed according to the comprehensive algorithm. We first inflate balloon, so this is a trivial question. We definitely
it's a trivial question, but you know already that we inflated the balloon and the patient is stable, and we don't have anything in the pericardium, so we have a bit more info.
Perfect. We know what we may do, and we know what we should never do. We will never give a protamine, yes, after fresh stents, and it usually leads to catastrophe. So, well, after inflating balloon, I can understand that we still have a spillage of contrast media into somewhere.
Exactly. So we can inflate the balloon many.
The cavity that we were filling with the contrast? What's the cavity there? It's not a tamponade, it's not a pericardium, so what's that?
the question is from, yes, exactly, that's a very good question. Is it a spilling perforation into a cavity? And from your experience from the image before, from this one, would you say that this is a cavity spilling perforation or not?
What I would ask the audience, what's the cavities is contrasted there? Distal, what's that? It is a type F perforation, the wire tip perforation, the terminal branch of coronary artery, and we can see some structure there, and maybe spillage somewhere in the cavity. But what's this structure? Is this hematoma, intramyocardial hematoma? What do you think?
I think it's going into the LV. I think the cavity that it's spilling into is the apex of the left ventricle.
Great cardiac vein?
Can be the vein, but you can see the part where the staining
After the
stays,
staining.
and you can see the staining, but you can also see then a bit of spilling at the end of the staining here.
No, but I mean, you can put the coils, but if it's a large cavity, the coils will just flow with the flow further and
Exactly. Would you put a coil, or that's a risk of actually embolizing the coil somewhere?
You can cut balloon. You can put an umbrella.
Then you might create a stroke by putting a
but
coil.
you can put a small balloon, cut the balloon, and leave a cutted balloon there, like an umbrella to block the distal artery. So the question is whether it goes into the large cavity, and if it's embolized, it may cause other troubles like embolization to the brain and so on, or it's filling some other cavity, some hematoma. So I don't care.
Exactly. So now that the patient is stable and we did so many inflation and he has nothing in the pericardium, we can already think that, of course, this is spilling somewhere else. And the question is it important to know if it's the vein, if it's the left ventricle, the right ventricle? And I would say yes, because one, if it's the left ventricle, the pressure in the left ventricle is high, so this actually you can call it a corocameral fistula that will never close because the spilling will be always in a high pressure. Or if it's in a right-sided cavity like the right ventricle veins and right atrium and so on, the pressure in the right side is lower, and that means, one, if you put a coil, it doesn't embolize into the brain, and second, if you leave it untreated, it may seal by itself. And that was our question: how can we diagnose where the spilling is? And I'm just gonna go on with a case because I want to show you that. As I told you, where I want to skip this slide, as I told you, we did multiple inflation many times. We stayed there almost half an hour, and you can see after half an hour of ballooning, the spilling is the same. So you cannot actually balloon tamponade the coronary cavity perforation, because the spilling will always keep it flowing. The flow is always there. So what we did, I mean, it was just an idea in the cath lab. Let's just not inject contrast, but a bit of saline. We take a 20 milliliter syringe, and we just take normal saline. We agitate it a little bit, and we inject it into the left coronary. And we also did TTE. We did an echo. And you can see here, I'm not sure if the quality of my image it's not so good because it's filmed with the smartphone, but you can actually see bubbles into the right ventricle here if you watch it. Can you see the bubbles?
Yes. So you injected agitated saline into
yes, but
LED.
not really agitated. We didn't take any air. We just a bit, not to create air embolism.
You have injected saline into LED and watched the bubbles in the right ventricle. Am I right?
Yes. Yes, and that's actually it's a simple idea to find which cavity.
Fantastic.
Is it. And then we stayed another half an hour. We got really scared, and then the question was, now knowing that it's spilling into the right ventricle, should we do something? We checked the pericardium. The pericardium was always free. The patient was really stable and asymptomatic, and actually someone looked on internet, and we saw some reports that you can actually leave those kinds of perforation alone, and they will seal them by themselves. So conservative approach, because putting coil might like you said, get embolized, and putting like stent grafts and so on, you can also create more complication and more ischemia by this. Of course, we were a bit skeptic, so we called the patient 3 months follow-up, and we repeated the angiogram, but you can see that the perforation sealed by itself. Just a similar case. I don't want to present you anything. I think I hope I have the images. It's a similar case what we encountered a bit later, I think last year. Yes. Also very interesting, during a CT or PCI of the right coronary, you can see again distal wire perforation, but this time it's very evident that it's spilling into a vein. So this time you don't need to inject any bubbles, because the contrast appearance is.
You can try to inject air.
Yeah. And already having a bit of experience with these types of perforation, with these times we were not scared as the first time. Of course, you need to do all like Ilya said. You need to go through all the algorithm, put a balloon, turn on the echo, do the echo, and so on, and alert everyone. But then when you can see that the pericardium is free, you can already think about cavity spilling. This is just a nice image I wanted to share with you, because it's I think it's pretty rare to see how the vein feels. And this is after 3 months follow-up. You can see that everything is closed. So, like we discussed, management in all types of perforations. The classical one are well defined, while the type C perforation has no clear indication, because they are rare and we don't know what to do with them. From our experience, perforations into low pressure cavities, like right-sided, you can just leave them alone, and high pressure cavities like LV aorta, the spilling may not close and actually create those kinds of fistula, and on the long-term follow-up, they can actually induce ischemia by coronary steal. Injection saline may reveal the cavity. Prolonged balloon inflation have inconsistent results. Like I told you, I've read many reports, and ballooning for a long time. Let's say keep the balloon for 1 hour. It doesn't really work. Coils and stent grafts, like I said, may come with costs, and they of course may be unnecessary, like in our cases. And if conservative treatment is chosen, you need to monitor the patient on the ICU for the first 24 hours, because the spilling perforation can actually transform into a classical perforation. So you really need to put the patient on monitor and do repeated TTEs to control if everything is fine. We also published these cases, and we tried to come up with the algorithm here on the right side. If it's a distal perforation, you need to inflate, like in any algorithm, inflate the balloon, call for help, open the echo machine. Is it hemodynamically stable? No. Then of course, that's a cardiac tamponade, and you need to do what you need to do. If it's really stable and asymptomatic, then you need to find the cavity. This idea with injecting saline is really cheap and simple. If you're not really sure, of course, you can do like multimodal imaging, CT, MRI. But to be honest, I'm not really sure if the radiologists can see better than we see in the cath lab. And if you can confirm that the fistula is in a low pressure cavity, from our experience, it's safe to leave it alone. Of course, it's like what we did from our experience. It's always good to keep the patient on the table for at least half an hour, you know, and do multiple injection. Make sure that the perforation is, you know, stable, and TT checks the first day. And of course, if you want to call him back, it's always good to repeat the angio just for your own comfort, to see that the perforation is closed. Thank you very much.
Thank you very much. Any questions for the audience before we move into the next case? Okay, so thank you very, very much for a very interesting case. So last but not least, Professor Sar Mincha, Lost on You, A Tale of Traveling Stent.
So I know that everyone is tired, so I'll try and share. This is a more of a healing process for me, because I have no idea what happened here. So maybe it'll help me. So this is a case of a 51-year-old male that presented with chest pain. He has a positive medical history for smoking and proteinuria, and presented with ECG, which seems to be quite normal. Labs elevated troponin just about the 60 to 75, EF of 60%, with inferior basal hypokinesis, and the working hypothesis was this is a non-STEMI patient. We went on and did an angio, and there's a quite normal right coronary artery. You can see the Circ2, and there's something going on here at the LAD, right? So that's the LAD. Would you stent this lesion? What would you do? Just think about it. Is this a normal end-STEMI patient? And this is why I have good friends. And
Nitro?
this is why I have bad friends. So the bad friends is sitting outside, say, give some nitro. I'm giving some nitro. It does improve, but still there is a lesion. Remember, the patient presented with end-STEMI. And he said, there's a new IVUS by Boston, ultra fast, ultra high res. Just do an IVUS. I said, just put a stent in. He said, no, do an IVUS. So I'm putting a wire. And then I said, why did I listen to him? So I just decided, I said, by the time you get in, put your IVUS in, I'll just put a stent in. So we did some nitro, no predil. Flow is getting back. You can see it on the right-hand panel. But I was able to put a stent in, so that's an Onyx 2518. And by the time he got dressed with his weird costume, the patient was stented, and I felt comfortable. All right, so the patient, of course, when he had the artery occluded, had ST elevation, had chest pain, occluded vessel. I put a stent in, felt comfortable. It's done, right? I post-dilated it to 3.0 because I felt that the stent that I gave after nitro was smaller than needed, and then I post-dilated it to a 3.0, and then the master came with his IVUS. I said, but the IVUS is open. Let's just do an IVUS. I said, okay, let's do an IVUS. So we did an IVUS, and that's the IVUS. It's ultra fast, very nice IVUS, but what do you see? Where's the stent? It's a 3.0 stent. Let me show you that again. That's the catheter. So we're pulling back. The stent was in the mid-distal LAD. Where's the stent? So this is where the stent is. The stent is here, in the left main. Yeah, okay. Yeah, that's exactly what I said. Ma. So we saw an IVUS that the stent dislodged from the mid-distal LAD to the left main. And that's exactly what I said after post-dilating it to 3.0. Ma? Okay. We don't need to translate that. So this is where the stent is. At the edge of the catheter, sitting there, floating, mocking at me. And this is where I ask you, what's the best way to manage this case? Should we microsnare it and pull it out through the guiding catheter, assuming this is a 6 French EBU? Should we gooseneck snare it, use a larger snare device and pull it? Should we secure the stent on the wire? Because if we start to manipulate this, it will dislodge and go to the brain. Or we should just go from a femoral approach, deploy the stent in the left main as an option, and maybe the best option in town, just send the guy for surgery. All right, so just vote for a sec, and we'll see how we can push this case through.
אתה יכול לעצור פה במקרים המוזרים, ניצחת.
We speak English in this arena, and this case just started. This is not anywhere near getting to the end of this case. Let me just turn off the QR. I'm glad that I'm winning. I'm just going to turn off the QR code so we'll be able to see the results. There we go. All right, so secure stent on the wire femoral axis, micro snare it, deploy in the. So I'm not sure I would deploy that. I mean, there's no disease. I'm not sure to deploy. I would start and pull it backwards, but would you stent it there? No, right? Yeah. So micro snare. Okay, so micro snare is usually at the verge of being a 3.0. So to capture a 3.0 full deployed stent, I'm not sure it's going to work, but it's an option. So this is where we kicked off. So first thing first, we thought of safety. This is exactly when Asa was presenting. This is exactly what I had in mind. That before, so Ilya was in the room giving weird advices. Said instead of listen to him, because I listened to him previously, I should just put a balloon, secure the stent distally, and prevent him from running off. Okay, so I was able to put a balloon through the stent, which is very easy because it's a fully deployed stent, a fully expandable stent, or expanded stent, I should say. And then we said, let's try, maybe, if everything goes well, we can pull it through the wrist, which was, I mean, we thought that it's not going to work, but at least try and see if we can secure the whole assembly. When it went all the way to the subclavian, of course, it failed, so that wasn't a good idea. Second thing was to do a femoral approach, and then it comes down to which equipment you have in the lab. We do have larger sheets, but at that point in time, the largest catheter that we had was an 8 French. So there's no point of taking a 10 French if you have only an 8 French catheter. So we switched for an 8 French sheath. We took an AL075. We took an end snare. And again, I don't know which equipment you have in the lab, but I'm sure it's a good advice to have everything. I mean, micro snare, gooseneck snare, and end snare. The good advantage of end snare is the ability to work in a 3-dimensional arena. So this is where we pulled the catheter backwards. We were able to snare the distal part of the wire, and remember that the balloon is still inflated. So the whole assembly is secured. The stent will not go further. And then we've advanced and we kind of rendezvous the two catheters in order to bring the stent closer to the femoral axis. We were also able to, or at least try to rewire retrogradely in order to do the same thing. Try to rewire retrogradely and pull with the balloon the stent towards the femoral axis. Does that make sense to you? Would you do something differently? How would you pull it backwards? No idea. Okay, that's fine. So again, the resolution that we had in order to close this case, we were trying to, as you can see, the stent at this point in time is crushed. You can see it here. Okay, because there was a balloon at the top, balloon at the bottom. It looks like a little ring. So we weren't able to pull it all the way through the sheath. So in order to create a full retrograde gear, we were using Ilya's technique of externalization of a wire. So from the anterograde, we had a wire in, and we deflated the balloon and replaced the balloon with a dual lumen catheter, allowing us to go from the anterograde to the retrograde femoral sheath, pass a 350 cm wire, and then we had the whole stent on a loop. And for that, because this is very not clear, I have a 3-dimensional example, or a model. So we kicked off like this. So we had a catheter at the top, catheter at the bottom. We had a balloon here, and the stent was here. And then we were using a dual lumen catheter through the stent in order to exchange the gear with a longer wire. So the stent is now over the wire, it won't go anywhere, it won't go to the brain, and we can try and pull it from the femoral side. So this is where it comes down to the solution. After externalizing the wire, we had a secured stent on the wire. We were able to pass the end snare, and just you can see that the end snare pushes the stent upwards. But again, the good thing about the end snare is the ability to twist it. So you can work in a three-dimensional arena and eventually pull the whole thing towards the sheath. So the stent was crimped with the end snare and was pulled backwards all the way to the sheath. And this is the delivery moment. So once everything was extracted, and we weren't worried about the fact that it will stay in the sheath itself because everything went through the catheter. So this is the delivery moment where you can see the end snare, and once the end snare will be open, you'll be able to see the little crimped 2.5 18-ish onyx stent. Okay, but remember, this was an end STEMI patient. So at the end of the day, we need to treat the patient, not the snare. So again, the colleague here said, listen, but still, this is an end STEMI patient. We did something to the coronaries. Maybe we should see the coronary. I said, we don't worry about the coronaries. They're fine. I said, no, just take a pic. So we took a pic and then decided to do an IVUS because the IVUS was open. So what would you do now? It's an end STEMI patient, but there's nothing in the coronary. And when you look at the IVUS, there's actually nothing in the IVUS too. There's like a significant, non-significant lesion, but there's no dissection, there's no thrombus, there's nothing there. Okay? So I'm not sure what was the original disease, but then we decided not to put a stent. We decided to treat this patient with a DCB because there was some trauma to this vessel. And we ended up that the patient went well with good LV function, bump of troponin went up to 91. I had no idea whether this was definitely not SCOT, but most probably spasm. And the patient was discharged later. So my learning points and my debriefing points, because we tried to debrief each of our cases. First, the clinical assessment, I think that the most important part was when in doubt, before stenting, imaging should precede intervention, especially, and right off the bat, I think that every interventionalist in the room saw the angio and thought this is not a regular end STEMI disease. Second thing is prevention. Balloon deflating and pulling should be performed with fluoroscopy. So if I debrief myself, after post-dilatation, I'm not sure I saw the balloon going all the way out before, so I didn't do that on fluoro. So if I were to debrief something, that was my mistake. You've just post-dilated the stent, make sure that you see that when you pull out the balloon, it gets pulled without pulling the stent out. So that was my main debriefing point. Now, when you treat with stent dislodgement will happen. And when we debrief it, if the patient is stable, think and plan. Call for help. As Elad said, and I think this is the most important part, call for other people. When you're out of the room, you can think clearly. Okay? And then safety first. Safety first meaning it will be really, really bad if you were to lose the stent. So to lose the stent and find it in the brain, that's not something you want to do. Use all the skills that you have in the lab. If you have a CTO operator, if you have a TAVI operator for vascular complications, so on and so forth, use all the gear, use all the equipment, and use all your friends to help you solve the case. And make sure you have relevant gear in your lab. This is why every time we have a complication, when we debrief it, usually some new equipment comes into play. And I think this is also something you want to consider when you debrief your cases. So with that, I thank you, and I'm open for discussion. If you don't have any questions, you were the one
we were unable to pull the stand, 3.0 stand in balloon. When we deformed it, it grew larger, even 3.5 or something, by the radial artery. We pulled it to the subclavian, and then we just switched to the femoral. And I wonder if we had any other option to pull it from the radial axis, maybe catching it by the proximal edge of the stent, not from from the distal edge from the stand.
I don't know if you remember, but I had a case like this with Nurse Shana. It took more than 8 hours. I pulled the proximal part of the stent and it starts, getting exactly like a long wire. Comments from the experienced panelists?
First of all, your retrieval of the stent through the femoral artery is mind-blowing. Is very cool, and I think it's very educational. And congratulations again on doing something heroic when you did not mean to do that at all. You can't pull it through the radial because it's a 3 millimeter stent in diameter with struts hanging, forward, and the mean radius or diameter of the radial artery is 2.5, 2.8 maybe millimeters. So all you could have done is tear up the radial artery or create damage. So going through the femoral artery is the only option.
Yep.
I just think it's amazing what really happened in the LAD. It's probably spasm.
Yeah.
I think when we discussed all the options, it doesn't look like SCAD on the intravascular imaging.
Nope.
And I think you had such resistance from the spasm that it pulled the balloon with the stent outside. You couldn't pull out. So I'm not sure, but it seems like that was the case. So intravascular imaging before the case could have given us an answer.
Yep. Any other comments from the audience? Yeah.
It's a great save, I think, but the fact that you have only 8 French catheter doesn't mean that the sheets itself shouldn't be bigger. You can put a long 12 French or even more from the groin, and then you can pull everything inside. We do it with an ASD or PFO device. If they run away, can even blunt cut part of the sheath too. So this is another option, but it's a beautiful save. Another things that we can do that we don't like, if we lose the stent, is rewire and crush the stent in the left main. Of course, we don't want that, but if there's no other
I think
option,
that would be the last bailout.
Yeah,
the one thing you don't want is lose it.
Yeah.
So there was a case like that, similar to that in the Euro PCR many years ago. So what they did, they inflate a balloon distally to the stent, they pull it back, they didn't damage the
Crash
stent, and they deploy it in the radial artery.
Really? That's also something you can do. Other comments, guys? All right, I hope this was fruitful. So you want to close the session, Maestro?
As you said,
Elad Maor, we're just closing the session. Thank you for sitting for 2 more minutes.
Final words. Thank you very much. As you've seen here, the complication can be tough and draining energy and motivation from even experienced operators. And during this course, we tackled 10 tough cases. Each of them was intense enough to make operators sweat and tremble. And however, we made them enjoyable and allowing open discussion and very friendly discussion without fearing of being judged or something. This experience is truly valuable because we had a very good opportunity to learn and to teach each other very many practical tips and tricks. Another very important thing we have here, our teams, nurses and technologists who play critical role during complication troubleshooting. They are essential because they are with us there in the real time. And this is really a team effort that's very, very valuable. This course is very impressive by its participation. We had almost a full room here. We had up to 50 to 70 in different times participants online via YouTube or Zoom. And it's large numbers, I think. It is a great success in my opinion. It is very relevant also because before we started this session, we had already cases lined up for the next session, so stay tuned. We are going to make another round half year ahead, maybe in the beginning of the autumn or something. And please keep in touch, and we will be very happy to see you again here. And thank you to Sar and to panelists and to all of you for attending this course. Goodbye.